Huples Cat. I just have a long video on the state of play in my province, Ontario in Canada, on about up including to the 4th of January. They just released today on the 12th of January, showing where we're going, where we've been, and what we're likely to face in the next few months. There's a lot of detail here. It's, I think, reasonably well explained. Anyway, grab a copy. This is about 21 minutes. There's a lot of detail, a lot of charts. It's really good stuff. Feel free to use this.
So key findings, as we do every day or every time that we make these briefings, I want to just call attention to a few key issues. Growth in cases has accelerated and is now over 7% on our worst days. Almost 40% of long-term care homes have active COVID-19 outbreaks. Since January 1st, 198 long-term care residents and 2 long-term care staff have died of COVID-19. And our current forecast suggests that the deaths in Wave 2 in long-term care will outstrip those in Wave 1. COVID-19 ICU occupancy is now over 400 beds. Surgeries are being canceled, and the access to care deficit will continue with real consequences for health. Much of this is due to the fact that mobility and contacts between people have not decreased with the current restrictions. Survey data do show that the majority of Ontarians are helping limit the spread by following current restrictions. However, case numbers will not decline until more of the population follows their example. A new variant of SARS-CoV-2 called B.1.1.7 could drive much higher case counts, ICU occupancy, and mortality if community transmission occurs. The doubling time for cases could drop by more than 2/3. And just to make it clear, this variant is in Ontario. This is not a hypothetical. The variant is here. It's just depending now on how fast it spreads. And without significant reductions in contacts, the health system will be overwhelmed and mortality will exceed the first wave totals before a vaccine has time to take effect. I'll move now to a chart that we show or start each one of these update briefings with, and this is the total new cases per 100,000 residents per week across public health units. I think it's pretty easy to see the dramatic recent growth as the slopes of those lines curve up quite strongly. I think it's important to note that all the public health units are now above restrict, and the majority are above the control line. So this is quite substantial growth. Moving on and looking at COVID-19 testing percent positivity across public health units. Again, you can see the dramatic growth in a number of public health units there, and all are above that control level now in the province. There is not a single public health unit, or any of the results that we present here that are below that threshold. And I think it's important to note that this is occurring despite strong testing volumes. So this is not an artifact of lower or reduced testing. This is persisting despite very strong testing volumes. I'll move on now to percent of COVID-19 test results returned within 2 days across public health units. We often talk a lot about the variation across public health units. You can see this variation persisting with rates going from about the low 60s to just into the high 90%. Fast turnaround of test results is critical to both helping people isolate at home so that they don't spread the disease, allowing people who are negative to actually go about their work, and as importantly, initiating case and contact tracing and helping control the spread. This is a number that's critical to fight against the disease and one that needs to move upwards. Moving on now, I just want to talk about the percent positivity by age group. We've truncated the chart a little bit here. We only go back to August now to give a little better resolution on the data. Again, the darker the square, and each square represents an age group, starting with the youngest age groups at the bottom, moving to the oldest age groups at the top. Each square represents one of those age groups. Right at the top, you can see the 75-plus group, the most vulnerable to COVID-19 infection, and you can see how that has darkened progressively over time. It's important to note, though, that all of these squares are darkening over time, and every square is over 5%, despite strong testing volumes. So, cases continue to rise, percent positivity continues to rise, testing is stable. This means that the growth of the pandemic is particularly acute right now, and at that point that is, I think, no longer we can describe as precarious, it is dangerous.
I'm Jean-Nicolas, the UNHCR representative in Yemen. Yemen has been labeled one of the worst humanitarian.
Let me move now to spend some time focusing on long-term care. You can see the curve here of deaths and cases. I think it's really important to call attention to that green curve, which is the cumulative deaths. This curve continues to become more and more steep. And as that curve becomes more steep, the number of deaths per day increases, or the number of deaths per week increases. And now, just thinking since January 1st, we've had 198 resident deaths and 2 staff deaths. Really important to note that this curve has increased virtually every time that we've given this briefing, and given the growth in cases, it will likely increase regardless of what we do, at least for a little while. I'd like to move now to some projections of mortality in long-term care homes. If you think that we had about 1,800 deaths in the first wave, we are now over 1,100 deaths. And under at least the worst case scenario, we would be looking at over 2,600 deaths by Valentine's Day, which is a significantly higher number than the first wave. That blue area behind the red bars are the actual deaths. That blue bar is the range of our estimation. You can see that now it's not going to be anything lower than 1,100, and there's a very good likelihood, given that slope, that we will start to approach that worst case scenario with a substantially higher death count in wave 2. Than in wave 1. I'd like to now move and start to show some maps of the progress of the disease across the province. Starting here on July 1st, you can see the map there. Every dot is a long-term care home in outbreak, and the size of that dot reflects the number of staff and residents who are infected in each outbreak. That gives you a picture of where we were at the start of the summer. Here we are at the beginning of October 1st, 2020. You can see that the number, let me just go back to July here, the number of dots has increased, and the size of those dots has increased as we go along here. And I'd like to take you now to really kind of today, or close to today. This is January 7th. You can see now that every region in the province has homes and outbreaks. You can see that the number of those outbreaks has increased, and you can see that the size of these outbreaks is substantial. So important to note that this is now spreading across all the province, and as we noted in kind of my introductory remarks, as this spreads, so will cases and so will deaths. Moving now to mobility. I'll first talk about mobility around retail. This is what we're using sort of cell phone and other types of data. We're able to understand where people are in terms of the types of places they're at. You can see that there was a very dramatic spike in retail before the Christmas holidays. This came down, people visiting retail areas. You can see, if you look very closely, that there are some gaps or drops in visits to retail that happen just after the lockdown measures are put in place, but not significant drops. And I think more importantly, it's really important to look at sort of an overall measure of mobility. The panel on the left-hand side of this chart is the changes in people's visits to workplaces. The panel on the right-hand side is changes in people staying at home. And you can see here across a number of public health units, really there is no change up until the actual Christmas holidays, and then it returns right back up to, at least as far as we can see from the existing data, right back up to the previous levels. So we're not seeing any real change in people staying at home. And I think it's important to note that this line is really flat since July, which means that we really haven't seen a break in mobility since probably the nadir or the lowest point of the pandemic, despite growing case numbers. I want to move to some survey data that has been commissioned by the Fields Institute here, and start to talk about people's behaviors. Great. So with current restrictions, almost 2/3 of the population are acting in a way that will decrease COVID-19 spread. And so, for instance, the top bar asks the question, are people in your neighborhood physically distancing? And about 25% say all the time. About 40% say most of the time, or at least trying. But there are 35% who report that people in their neighborhood are occasionally or never physically distancing. And that's a key step in actually breaking the transmission of the disease. Looking a little more into what will have been happening around the holidays here. In the last 4 weeks, how many people outside your household visited your house for a meal or a celebration or a stayover? about 32% of the population reported that 3 or more people visited the house. And for those who reported people visiting the house, a third did not observe restrictions, such as mask wearing or physical distancing, which is key to actually preventing the transmission of the disease, particularly if this is indoors. So about 2/3 of the population are working to try to break the spread of the disease, but I think their efforts will go and be undone if the entire province does not pitch in here. Now let me go on to projections here. As before, what we do is we project based on the existing or current growth in cases where we think it's going to go. You can see there that really with case growth between 3 and 5%, that's the second and third line from the top, we're really pretty much exactly where France and the UK and the Netherlands are at the same point in their pandemic growth. And so we're facing the type of growth now that those jurisdictions have felt the need to take decisive action on to restrict. I won't get into the overall case numbers, save to say that if we do hit the 5% level of growth, which is quite possible, we'll be looking at over 20,000 cases a day by the middle of February. And if we get into a darker situation with 7% growth, where actually we have seen some days at 7% growth, we'll be looking at over 40,000 cases per day. This, of course, unfortunately translates into dramatic reductions in intensive care use. Dramatic reductions in intensive care unit capacity. And so we're already over 400 beds. And by the end of the first week of February, even under a very optimistic scenario of 1% growth, we will have over 700 beds filled. If we're at a more reasonable range between 3% and 5%, we'll be looking at 1,000 to 1,500 intensive care unit beds occupied by COVID-19 patients. And obviously at that point it's no longer a possible level of capacity to support because we are expending the majority of our capacity in intensive care taking care of COVID-19 patients. We haven't shown a 9% growth rate, which is what is threatened by some of the growth that we've seen in other jurisdictions. But if we did, the number would be an almost impossible 2,000 intensive care units, intensive care unit beds occupied by February 5th. Continuing on here, I want to show the slide on intensive care unit admissions and hospitalization rates overall. For the last several briefings, we've been reporting a roughly consistent growth in this number each time. You can see now that over the past 4 weeks, there has been a 72% increase in hospitalizations and a 61% increase in intensive care unit patients. Given the growth in cases, given the increase in percent positivity among our older age groups, this trend will continue for a while. I'd like to now talk about the distribution of these intensive care unit beds across the province. It's important to note that we now have about a quarter of our hospitals with no ICU beds free, and another quarter have only 1 or 2 beds free. I think it's important to kind of present this because we're now looking at a situation where half of our intensive care units do not have the capacity to respond to emergencies, medical emergencies, whether it be for individuals like a heart attack or emergencies that might affect multiple people such as violence or motor vehicle accidents. I also want to note that these hospitals facing crisis now are distributed across broad parts of the province. And perhaps as well also note that the hospitals that are most affected are also referral centers for the entire province. So this type of ICU occupancy compromises care across the province. This is no longer an issue of 1 or 2 regions, and it's no longer an issue of moving patients around to try to accommodate access to care problems. I want to note here the continuing access to care deficit. You will see a sharp blip up in the volume of surgery done over the Christmas holidays. This is a blip up not in terms of absolute numbers in a way that would give us any comfort. This is compared to the volume of surgery over last year's Christmas holidays, which is typically a slow period. But you can see with the close of the holidays, that surgery has actually started to decline substantially again below 2019 levels. And just to kind of put this again into perspective for people, when we start to delay care, much of what we talk about in terms of tumor doubling time is measured in weeks. Cancers get larger, prognosis gets worse, and patients will die. Heart disease will worsen, and patients will die as they're unable to get access to care. But perhaps as importantly, there is large swaths of our healthcare system that are similarly compromised, everything from mental health care through to addictions care, through to care for chronic diseases. All these become compromised, and this builds up not only an access to care deficit, but a substantial health deficit that will persist and will be as inequitable or more inequitable than the rest of the pandemic. Of course, this translates not only to problems in access to care, it translates in problems in mortality. Daily mortality is increasing, doubling, if the trends persist, to between 50 and 100 deaths per day between now and the end of February. To give you an idea of this in relationship to other causes of mortality, this would really put COVID-19 into competition for being the single greatest cause of mortality on a daily basis at that point, potentially larger than cancer and heart disease. It's already larger than virtually every other cause that we look at, but this will put it into the first position with very little opportunity from challenge. Now I'd like to talk about the new variant of COVID-19, the new variant of SARS-CoV-2, B.1.1.7. And this is the variant that appears to be much more easily transmitted. We look at it as probably being about 56% more transmissible, but we're pretty confident that this increase in transmissibility, the ability for it to move around and infect other people, is at least 50% and maybe as high as 75% more transmissible. Fortunately, there's no increase in disease severity, and the vaccines are likely still effective. But the critical issue here, as case numbers grow, as that transmissibility leads to higher case numbers, it does lead to more hospitalizations, it does lead to more intensive care unit occupancy, and it does lead to more death. It's not an issue of changing the rate, it's really an issue of changing the overall number. Let me now talk about what this does to our modeling projections in terms of numbers of cases. Just advance the slide there, thank you. If the SARS-CoV-2 variant B.1.1.7 spreads in the community, the doubling time for cases could drop to 10 days in March. Now, what you see here in the blue dots is a series of scenarios that we're running around the current variant of SARS-CoV-2, how its transmissibility leads to growth in cases. And you can see superimposed on that a black line. The black line represents what our models are predicting, and the blue dots represent all the different ways we've tried to run this scenario. As you can see right now, our models are functioning fairly effectively and doing a good job of predicting what the growth is. However, the red lines indicate the growth in new cases that would result from the new variant, B.1.1.7. And you can see that if we've had one case introduced into Ontario in mid-October, even if there's a chance that 2/3 of any of these new cases introduced don't get transmitted at all, you can see that explosive growth in the red dots as the total number of cases take off, and the disease starts to get to almost near vertical growth in cases. The red dots obviously start to go vertical. The gray dots are the total number of cases, but you can see just how quickly that new variant dominates the transmission and leads to a much, much higher level of cases and a much, much faster rate of transmission. One of the questions we get asked often is what are the key components of what other jurisdictions have done to try to curb this spread. You can see here, as we looked at, say, Victoria, France, the United Kingdom, Germany, or Netherlands. It's important to know as well that United Kingdom, Germany, and Netherlands all have these lockdowns in progress right now. Stay-at-home orders, restrictions on movement, as we really saw in the first wave here in Ontario, are a common element to all of them. You can see a number of elements about really kind of closing non-essential activities, really strong attention to workplaces as well across all of these, and the importance as well of enforcement of this. Now, it's, I think, important to emphasize the value of enforcement and making sure that people understand what's going on and the importance of adhering to the public health restrictions. It's equally important to note, though, that it must be enforcement and support. So that people don't have to make choices that no one should have to make about actually protecting theirs and others' health. Returning now again to the key findings, growth in cases has accelerated. It can no longer be described as precarious given the persistence of a R above 1. It's over 7% on the worst days, which is getting into our worst case scenario territory strongly. Almost 40% of long-term care homes, or really 40% of long-term care homes, have active COVID-19 outbreaks. And since January 1st, almost 200 residents and 2 staff have died. Our forecast suggests that this rate of death will just continue to accelerate, and the cumulative death count is on track right now to outstrip that in the first wave. ICU occupancy is now over 400 beds, and our scenarios are predicting that this could easily double by the end of the first week in February. Mobility and contacts are not declining as we would hope in order to break the transmission of the disease or the spread of the disease. Mobility levels are really staying very similar to what they were in July, which means that the current restrictions will need to be augmented if the goal is to reduce case spread, reduce the crisis within our health system, and save lives. The new variant could drive substantially higher case counts. This will require hard work in case and contact tracing. It will require public health capacity to be able to control the spread of this new variant, and the ability as well to identify this new variant regularly using sequencing. And without significant reductions in contacts, the health system will be overwhelmed, and the mortality will exceed the first wave totals before a vaccine has time to take effect. I'll just conclude by noting the members here of the science and modeling tables who have contributed to this presentation and all the preceding briefings, and I'm very proud that they've been able to do this.
The guy doing the narration does actually make a couple of errors at a few points, but when he's saying the black line is projections, it's actually not, it's actually recorded daily cases. So our modelling to this point has been good, but the British variant, B117 of COVID SARS, is going to absolutely destroy any of the projections we have, and the projections we have are catastrophic. My hospital is one of the hospitals with 0 ICU beds day to day. Literally as soon as somebody dies or we transfer them out, there's already patients waiting to enter those beds. The situation is very dire. I would like to point out that the 32 to 34% of people in the province of Ontario who are not obeying sensible and smart public health precautions like distancing and masking and washing hands and not gathering in groups are actually making the lockdown occur and are actually making the economics of this much harder for everybody else. It's no longer going to be tolerated as much as it was in the past. I do expect there to be an increase in police measures against people who decline, for whatever reasons, to accept the infringement of their civil liberties in a time of an airborne pandemic. It really is smart. If you don't agree with mask wearing, if you don't agree with the lockdowns, that's fine, but don't leave your house. You are really endangering the rest of us who actually understand what's going on, and you're also going to put yourself front and center into a very unhappy situation in terms of how you're going to be treated, both by your employers and also by the police. I do expect people to be fired if they're arrested for breaking lockdown. There's no reason at all under labour law, if you bring discredit or dispute to your employer, why they can't just terminate you. From what I know as a hospital administrator in a major downtown teaching hospital in Toronto, it's accurate, and I think that's important. The fact that staff are still dying in this week and we haven't had them die for a long time, the fact that in my own place of work, daily we get outbreaks on floors, daily we have people coming positive who we didn't know they were, had no idea they were, and the same is also occurring in the staff. We are going to lose people. The British are saying quite clearly that about 25% of all ICU deaths are under 50 and most have no comorbidities. The effect of the virus has changed. Whether the virus itself has changed is a moot point. The effects are, this is no longer a virus that just imposes a severe threat to the elderly and a slight one to everybody else. It imposes a direct threat to everybody in every age group. The older you are, the sicker you are, the more likely you are to die from it. But you are likely to die from this in a significant minority of cases, no matter your age group, no matter your health. This has been a Wolfie Terrier production 2021.